Hello everyone. Our today's topic is cholelithiasis. We are going to understand the relationship between cholelithiasis and total parenteral nutrition. Risk factors, 4Fs, everybody knows that, like pretty common, that female, fat, fertile, and 40 are usually linked with cholelithiasis, but make sure you don't neglect other things, like you may see question in which there is a male represented with gallbladder stones, right? So don't limit yourself to these risk factors. There are a lot more. We are definitely going to cover all of them today. So what are the most common complications in cholecystitis? Um, the most common complication of cholelithiasis is cholecystitis, and I have a separate video for that. You can find it on my channel with the name of cholecystitis, and I'll try to put the link in the description too. You'll find it there too. Another complication is acute pancreatitis and ascending cholangitis. We can diagnose cholelithiasis with ultrasound and treatment with elective cholecystectomy if symptomatic, like if the stones in the gallbladder are causing pain or are going towards any complication, then definitely we need to do cholecystectomy for the patient. So there are two main types for cholelithiasis. One is like cholesterol stones, and the other is the pigment stone. Cholesterol stones arise usually inside the gallbladder, and these are like due to abnormal cholesterol metabolism can cause it. If there is hypersaturation of bile, like bile salts are less and there is more cholesterol inside the body, so then bile salts will be hypersaturated with cholesterol, and then calcium will deposit in them and it will convert it into stone. Next, another type is pigment stones, which could be either black pigment stone or mixed brown pigment stones. So the cause of black pigment stone is hemolysis. When hemolysis happens and calcium deposited in the bilirubin, in the unconjugated bilirubin, it will make black pigment. So these are also arise mostly inside the gallbladder. But the third type is mixed brown pigment stones, and these are usually seen in the biliary ducts. So there's another different term used for that, that is cholelithiasis. So biliary infection or infestation is the cause of mixed brown pigment stones. So as I showed you in the last picture, there are two types of stones. One is the cholesterol stones. These are radiolucent. These are 10 to 20% opaque due to calcification. 80% of stones are cholesterol stones, and the remaining 20% are pigment stones. So what things they are associated with? As I explained you in the first slide, that we usually consider risk factor related to female, 40, fertile, but there are other risk factors too, or associations too, like obesity, estrogen therapy. We know that like multiparity, we know that. But they are related to Crohn's disease, advanced age, rapid weight loss, total parenteral nutrition, Native American origin. All these things could be in men too, in males too. So there are quite a lot of chances that in scenario you will see a patient represented with a history of Crohn's disease, or he's old, or he had rapid weight loss in the past, or he's on total parenteral nutrition. Excuse me. So there are chances that you can see these things in the question. Second type is the pigment stones. So as I mentioned before, there are two types: black pigment stones, brown pigment stones. Black pigment stones are radiopaque. Calcium plus bilirubin deposits, usually caused by hemolysis, can result in formation of black pigment stone. There's another type that is brown pigment stones. These are mostly radiolucent, caused by infections or infestations. So these are also associated with Crohn's disease, chronic hemolysis, alcoholic cirrhosis, advanced age, biliary infections, and total parenteral nutrition. So you have seen like total parenteral nutrition can cause both types of stones. So what is total parenteral nutrition and how it happened? A prolonged course of total parenteral nutrition is often complicated by gallstones. As you see in the picture, what happened normally in a normal person, in a normal individual, we eat food from the mouth, it enters into the esophagus, from esophagus it goes into the stomach, from there it enters into the duodenum. Our duodenum release hormones like CCK. That stimulation for the release of CCK is caused by the food intake through the mouth. That CCK helps in contraction of the gallbladder, which cause bile to move. What if someone had a surgery and had removal of part of the colon? That person is on total parenteral nutrition. That person is not taking food through mouth anymore. There would be no stimulation for the CCK release in that case. If there is no CCK release stimulation, there will be biliary stasis in that individual. So for that purpose, there are more chances that that individual can develop gallbladder stones. So what is the pathogenesis? Cholesterol is secreted in the bile, where it is solubilized by bile salts and phosphatidylcholine. In any situation where there is more cholesterol and less bile salts, obviously there will be saturation. So if there is more cholesterol than can be dissolved by the bile salts, the cholesterol will precipitate into insoluble crystals, leading to the formation of gallstones. Increased cholesterol or bilirubin will be seen in those patients. There will be decreased bile salts and phosphatidylcholine in those patients. So bile becomes supersaturated with cholesterol. There will be aggregation promoted by mucus hypersecretion, calcium salts, and gallbladder stasis. All cause cholesterol stones. So it's time for the question. We have covered pathogenesis, we have covered risk factors, we have covered association. So here comes the question. A 64-year-old man presents with acute onset right upper quadrant abdominal pain, nausea, and vomiting. It's very obvious that patient is having colicky pain. The patient had extensive small bowel resection due to bowel ischemia a year ago and has been receiving total parenteral nutrition (TPN) since then. Examination shows right upper quadrant tenderness on deep palpation. Lab studies show moderate leukocytosis with normal hepatic transaminase, amylase, and lipase level. That means liver is not affected. Liver is absolutely fine in this patient. Abdominal ultrasonography reveals gallstones and edema of the gallbladder wall. It means that cholelithiasis is leading to cholecystitis because there is edema of gallbladder wall is happening. A review of prior records indicates that he had no gallstones noted on abdominal imaging performed prior to bowel resection. Which of the following is most likely responsible for gallstone, the development of gallstones in the patient? Excuse me. Options are A. Decreased cholesterol conversion to bile acids due to liver dysfunction. B. High cholesterol content of the nutritional fluids. C. Deficient supplementation of essential fatty acids. D. Decreased CCK release due to lack of enteral stimulation. Now, think about option A, decreased cholesterol conversion to bile acids due to liver dysfunction. Is it responsible? No, there is no liver dysfunction in this patient. Option B, high cholesterol content of the nutritional fluids. Nutritional fluids doesn't have cholesterol in there. Nutritional fluids generally have proteins, carbs, fats. It depends on the patient need, what is lacking in that patient, which nutrient is lacking. It doesn't have cholesterol in there, so option B is wrong. Option C, deficient supplementation of essential fatty acids. Essential fatty acids deficiency is not cause of cholelithiasis. We haven't seen it anywhere. So option D, decreased CCK release due to lack of enteral stimulation. Yeah, this is the right answer, as we have seen in the previous photograph here. So that's it for today. If you guys have any questions, please let me know in the comment section. I'm sorry for the cough, and I'll attach all those references in the down there too. You'll find those links there too. Please make sure to subscribe my channel so I can continue making these videos for you. Thank you. Bye.